We heard a lot about AI right now. We heard about frameworks. We heard about policy or lack thereof and deregulation and such. You also saw some real-life examples from healthcare systems, including folks from Kaiser, as well as Ochin, around how AI is being used. And the big flavor was automation, assistance, efficiency, personal productivity. Still, there is some longer road to patient outcomes. We'll switch gears right now and talk about AI very much in the context of California. So what's happening within AI and with a focus on California. And we have a great speaker, Dr. Ghaly, who is going to be talking about that. He was appointed Secretary of California Health and Human Services Agency in 2019 by Governor Gavin Newsom and recently stepped down after 6 years of service. In serving California, he's had the privilege of working with partners across diverse sectors and disciplines to improve the lives and life chances of all Californians, which is very true during the COVID time, and that's where I've heard so much from you. And so let's welcome Dr. Ghaly, and he's going to talk about AI, the next frontier.
Great, okay. Let's get this, there we go. All right, great. Thank you for welcoming me and having me be sort of closing this down a little bit with the California perspective. The last panel, terrific. A lot of great insights about where AI is heading, what those opportunities are. I'm going to try to bring it down a little bit to the California context and share a little bit about my own journey thinking about it in the seat I just left a few months ago. And then I have some slides that really focus on what I think Sylvia on the last panel focused on, which was, how do we make sure that the safety net is not left behind? Part of why that is a focus for me in particular is our state has the largest Medicaid program in the nation. During the pandemic, when we weren't disenrolling folks off of Medicaid, 1 in 3 Californians were on Medicaid. Half of the births supported by Medicaid in this state. 2/3 of our nursing home days paid through Medicaid. Huge program. I can tell you that a decade after continuous glucose monitoring was sort of mainstay everywhere, Medicaid finally started to pay for it in California, and we're one of the leaders. So the tendency of the safety net is to be late adopters, have a lot of regulatory or other barriers, and my hope is that that's not the case here. All right. So when I told my son that I was coming here instead of his baseball game, he asked why. And I explained to him what I was going to do. He said, you should ask AI what AI thinks about how it's going to transform healthcare. So I did that, interesting idea. This is a summary. I didn't ask AI to do the summary, but I did ask AI what they thought. And I think loud and clear, there is this tremendous opportunity that I think we're all sort of on the edge of our seats to see where does it take us as a healthcare delivery system. California has advanced a pretty aggressive agenda around healthcare affordability, really bending the cost curve, setting some fairly nation-leading aggressive cost growth targets with an entire sort of regulatory and fiscal framework on what happens when entities don't meet those cost targets. The question will be like, does AI help us get there? On the safety net, can we imagine where the personalization of AI tools allows us to take care of patients in a radically different way? I enjoyed the last panel's conversation around how can this help us, not just at the system level, but on the specific issues that patients are facing. No doubt there are some great opportunities. Yes, we know about patient monitoring, efficient opportunities. The drug development opportunities seem endless and tremendous as well. But then there are those challenges and considerations, and I'm going to get into a little bit about my journey thinking about what does California's regulatory framework, what should it look like? How does it sort of piggyback off of or even lead the federal framework? And I think these are reasons why safety net institutions are often slow. Yes, agree that funding and investment and the ability, the narrow margins don't allow that adoption, but also concerns around data and privacy, security, this issue around bias and fairness, a major one, of course. And then the fact that California has not yet developed those regulatory frameworks that I think maybe some are expecting us to develop, either within the state or across the nation. And how are we going to get there, I think, is a key challenge for us. So we heard a little bit about how slow, frankly, the safety net is in adopting technology. And I think there's a number of reasons for that. We've gone through some of them. But I can certainly tell you that as a primary care physician in San Francisco, when I finished training, I was in a public clinic running that clinic with a huge medical records room and a number of paper files, taking notes, on paper, having nurses or MAs take the orders off of those charts. And then I would, at night, moonlight at Kaiser, and had a very different experience getting onto Epic, working through those challenges, but really a tremendous and a very different experience. And I think that is very much that parallel nearly 2 decades ago is something that you still see in that safety net. And I think one of the prior panelists said it nicely, in our rural clinics especially, we still don't have the level of EHR adoption that one would expect. I can't imagine most of you in this room get their care in a system that doesn't yet today have an electronic health record. But yes, even in California, where we're sort of the home to so much technology, we have millions of Californians who probably don't benefit simply from this technology. And when they do, we often are stuck with version 1.0 or 2.0 in the safety net, not the most evolved or most capable systems. So that transformation just takes a while. This I found fairly interesting because I did some look around to see what safety net systems seem to be pushing forward. And we heard about ambient dictation. I agree with one of the prior panelists. No matter what you think as a patient, clinicians are really embracing this. It's changing their lives. I have yet to meet a clinician who is using this technology who says, I want to go back to the old way. It saves them time, yes. It helps them formulate the thoughts. It helps them be present with the patients. All of the above allows clinicians to do the job that they largely went into clinical medicine to do, which is be with patients. So what are the unique opportunities in the safety net, and can we finally catch up? While I was secretary, we had a saying that we want to lift all boats, but some more than others. And I think the AI opportunity is sort of that as well, right? We're going to have a chance, if we think about it wisely and are strategic, through our investments both at the federal and the state level, to make sure those safety net institutions have the resources to play in the game as well as anybody else, we may actually finally catch up. So one of the things we did, one of the first states to do it, but certainly not the only state to do it, was as part of our Medicaid program, we created what we call a community health worker benefit. And what that does is allow care teams that need extenders beyond the sort of 4 walls of their clinic to employ and use a community health worker. And in my own experience, those community health workers that I used running a public health clinic in San Francisco for a number of years, they were the game changer. They were sort of the amazing connector to the community. My community health worker knew before my day started which patients were and which patients weren't going to come in. They were a deep part of the community. They understood things. But limited in their capability of really delivering a clinical message, helping the true management of the patient. They were great at sort of those case management functions and connecting some dots, but they didn't play a huge role in actually delivering care. And then it meant that any real change to the care plan or any opportunities to impact their care had to flow through the clinic and the physician. Community health workers, at least in California, are a more readily available workforce. We have lots of folks who moved to the United States and California who had a role as a healthcare provider or a health professional in their home country that we don't use in our health system, in part because we haven't figured out the role that's right for them. I think this role of community health worker enabled with an AI tool could really advance California in a way that we haven't seen in quite some time. So if we're thinking about community health workers or other roles that traditionally haven't been as active or important in the actual care delivery, how do we make sure that however we're using AI, we're thinking about these sort of core values? And about a year ago, my team sat down and looked at the federal HHS framework on AI and advanced our own set of core values around AI adoption for California. And these were generally the list. I think they're very similar to what many of you have seen, but they were lists not just as cautions, but as opportunities. Of course, we need to make sure that algorithmic bias is something we're thoughtful around and pay a great deal of attention to. And is it an opportunity through how AI is trained, the data that actually drives where the AI goes, that we can actually not widen the bias, but narrow it in a way? Is this an opportunity rather than just a risk? And I think California looks at each of these core values as an opportunity, not just risk. And the challenge, though, is how do we organize ourselves in California to be the kind of leader that I think the nation, or at least our state, expects us to be in this space. And I will tell you, to date, that certainly hasn't happened. So I'm going to move on to more where California is in this entire sort of journey. September 6th, 2023, Governor Newsom signed an executive order around AI for the state. And it was meant to do a number of things, but it also was meant to unleash where our state agencies went with AI. And at the same time he signed the executive order, he asked for a few sort of early adopter agencies, and I raised my hand for HHS to jump in. And we did a number of things as a result, and I think they're going to start paying off this year. We decided to explore 2 proof of concepts within the health and human services space for statewide adoption of AI. One, neither are huge splashy moments, but it is allowing us to create and design that muscle that I think will allow us to more aptly adapt and implement AI in the future. One was around statewide translation of materials. So sounds like a simple thing. We have literally hundreds of staff at the state and across our county systems who are in charge of helping us translate information into threshold languages across the state. So consumers, patients, beneficiaries in a number of systems have information in the language that is their primary language. In this AI proof of concept, the goal will be to both cut down the amount of time it's going to take to allow us to get that translation to be widely available, but also to help support those staff in quality reviews and making sure that we stay closely in touch with those using the information to advance either connections to benefits, asking or answering frequently asked questions, or even real-time translation of immediate beneficiary questions. That process for the state of California to take on, find the partners, really go through the exercise of getting folks on board with this was quite a big challenge. We had to address a number of labor related issues that I think are relevant, not just within this proof of concept, but beyond. The adoption widely of 58 counties for 40 million Californians, another big hurdle. And the goal was to really create a venue where we get to test out our ability as government to not just adopt it, but lead it in a way. The second proof of concept, which we are hopefully, the state will hopefully continue down the road of partnering with the federal government, was on facility surveys. We have hundreds, thousands of long-term care facilities in California, just like the rest of the nation. We are unable to keep up with the types of surveys that our federal partners require us to have, largely as a result of workforce shortages, difficulties accessing our facilities, and just the entire process of conducting these surveys. Creating a job aid was our second project to support how that work and those surveys happen. Seeing into the future, how can AI help us on hospital surveys, other facility surveys, supporting the technical assistance and being that job aid, not just to the surveyors, but the facilities themselves, which we hope will obviously increase patient safety and the quality of care. So these are two small places where California is sort of taking a lead and figuring out how AI is going to support not just safety net providers, but providers across the board. What I want to wrap up on before I open it up to questions, and would love to hear thoughts from others around what a regulatory framework will look like at the state level. Post the executive order by Governor Newsom, I had the privilege of going to Washington, D.C. on a number of different issues, but the opportunity, we asked for a meeting with the leader in HHS, federal HHS, around AI in healthcare. And this was roughly 18 months ago. And I was guided while I was there into a small office with no windows to meet with the single person who was in charge of thinking through this. And I think that is very telling of how we, both at the state level and at the federal level, have really been behind on where we're going to go and how we're going to lead this conversation. Governor Newsom, through the executive order, really ignited a whole set of conversations between our union workforce partners, between our tech companies in Silicon Valley, and just the wealth of leaders in this space with our legislators to determine how are we going to sort of move this entire regulatory framework forward. Big picture, right? There's the existential risk that I think many people are worried about. I think less so is that going to be where California steps in. It's going to be a lot more on use cases and sort of end user impact. We're already having conversations across the state. I think one speaker shared a couple of bills that advanced last year, regulating the ability to use AI without notifying patients that AI is being used in either advancing information, answering questions, and all of the above. And then the second place was in the determination of medical necessity in insurance claim disputes. So AI can be part of those decisions, but cannot be the final decision maker. This sort of human in the loop concept was very much real there. I think this year, and our state legislative deadline is tomorrow, so new bills with clear mission will be advanced by tomorrow, so we'll get a good lay of the land. There's not a lot there yet in the AI and health world, but we expect that tomorrow and over the next month, we're going to see quite a bit of different legislation that really focuses on how California is going to explore this intersection between how do we take this sort of real great opportunity and advance in an offensive way the ability to change how healthcare is delivered versus what I think largely has been the conversation over the last 2 years in Sacramento, this focus on how are we going to be defensive, how are we going to protect information, how we're going to protect patients in general, prevent bias, and promote equity. So these, I think in the next couple of weeks, this audience, as you pay attention to what's happening locally, will have a chance to see really where both the governor and the legislature are and how industry has impacted their view. So I wanted certainly to just have a chance to share that perspective in our brief journey, hopefully punctuate this point that a place where I believe California will lead is how is AI sort of integrated and built into our Medicaid program. I appreciated Sylvia's comments that in the past, the safety net has depended on major resource infusion from either state or federal partners. I think that's going to be the same here. Many of you may remember high tech and some of the other EHR investment efforts, both federally and at the state level. Imagining what it's going to take to keep the safety net up with AI is going to require something similar. We've done that in the past. We've had the ability to make big investments to prop up and support that system, and I think it's going to be required again for sure. So let's see. I don't know if we want to, yeah.
Thanks for that overview, Mark. I'll kick it off, and then we should have some audience questions. Already I can see people raising their hand. It's great that a bunch of panelists talked about California being ahead. The big theme from the panel before was, yes, we are using AI. We're using more for automation, administrative simplicity, efficiency, to some extent experience with the ambient typing and whatnot. As you think about California is ahead, that community health worker absolutely endorse that role. Is there a role for the state, especially as we are doing CalAIM and half the kids in the state of California are in Medicaid, to kind of jumpstart and have public-private partnerships to advance AI? So the children's hospitals, there are other hospital academic system. Is there a role for the state to kind of come alongside and start thinking about it from a scale perspective, in addition to automation and experience and administrative simplicity, to kind of get to that quintuple aim in a way?
I mean, easy answer is absolutely there's a role. I think if we don't serve that role and we don't ensure that it's scaled broadly, the group left behind will be the Medicaid population. So in order for it to scale equitably, I think it's going to require state involvement, not just from investment, but organizing. One of the last things I did in my role as secretary last fall was kick off with the California Healthcare Foundation a series of listening sessions with safety net providers across the state, Southern California, Northern California, parts of rural California for sure, and hearing both the excitement, anxiety among those providers. I think to cut through it is going to require some deep organization by the state to make it happen. And What I would like to see is certainly, as we have in other advances, whether it's in the housing space, the broadband space, where we really push our private partners who are developing the technology to keep the safety net populations in mind. It has worked in a number of other settings, and creating some requirement for that, I think, will help us kind of live up to that lift all boats, but some more than others principle.
Big audience, I see, Mark.
So can you hear me? Yeah.
Yeah.
I'm happy you brought up meaningful use, high tech for EHRs. So one of the things we've been advocating for in Health AI Partnership is this precedent that we have both from EHRs and telemedicine, where you actually fund infrastructure, purchase of the technology, and technical assistance programs. I think a lot of what we did last year was at the federal level communicate the need for that. I don't know how that message will be perceived in this new environment. So I'm curious, like, even in your comments, you're saying that obviously before this has been federally coordinated, but I'm curious where we are today, what should we be doing, whether it's California or other state levels, to try to motivate that type of action at the state level?
Yeah, I mean, the opportunity to educate legislators on how important that is going to be will be critical. I think that many of us in either the advocacy space or the clinical advocacy space expect legislators to either know this already or have the information coming to them in a different way. And I think that is going to be really key, that they get the information, that those programs that helped EHRs or telemedicine were very effective for X, Y, and Z reasons, and we need to replicate that. This year, next year, will probably be a really challenging time for certain states to make state-level investments. But anything like this takes a couple years to build momentum around. And so now would be the time to suggest a similar type of program at the state level. A couple of years ago, we funded, and California scale's always a little bit off versus other states, but invested $300 million in clinic transformation activities to support small, medium-sized practices to both redesign their models of care as well as adapt and bring in new technology in order to pursue value-based payment arrangements with payers. That has been something long in the making, a huge investment at the state level. I can imagine something similar happening as we get more sort of the drumbeat, where AI really is something that we can safely promote within the health delivery space. I think it's going to be less focused around administrative efficiency or some of the other benefits that I think panelists have talked about with AI. I think the patient impact, the care impact is going to be really the leading voice for a lot of legislators to feel this is worth spending state-only dollars on. Oh, go for it. Oh, it's coming.
We've spoken a little bit about equal access. And when I think about AI in healthcare, one of the inevitable things that comes to my mind is data. I do research with AI, and data sets are pretty hard to come by that are clean and useful. And every single hospital space is different. We just had the CMO from Optum come and speak in Dr. Batra's class. And you know, one of the struggles that they deal with is that they have a lot of data silos. And it makes it so that if you're trying to innovate and you know, implement AI in a system, you have to make it different for every single different data silo. So my question to you is California doing something similar to FHIR or SMART, which was implemented in 2011 and 2020 under Biden, that is actually going to be put into use to make at least some sort of similar data ecosystem that can be used so that those rural places in California can have access to this kind of tech, not just San Francisco?
Yeah, it's a good question. I think, so we advanced a few things, and I will admit that as much of a leader as California is, this is a space where we haven't been. When I came into the role 6 years ago, we began looking at even just simply health information exchange and where were we relative to other states. And at best, we were middle of the pack. We advanced a sort of data exchange framework concept a few years back that is a requirement now for all major providers and systems to sort of go into a statewide HIE, not a single HIE, but something that fed all the information together, and not just health information, but also the social service resources or access points for patients. So, not only when a person walks into a different emergency room can that information be available, but hopefully, whether it's your care coordinator on the social services side looking for your housing or your primary care provider, they would have the ability to see that information and use it to not just look at the population health impacts of whatever they're looking at, but also to help manage that patient. And partly we pushed for this because of that issue in rural health settings, which had their own struggles and were never going to be able to invest in it all on their own. I think the question I would ask, is that enough to really put them in a position to then be able to seamlessly adopt AI? I don't know the answer. I think we're going to have to see. It certainly feels like a required step, but not enough. And we're still going to need a bunch of TA, a bunch of new technology and supports to make it sort of worth the full impact that it could have.
There.
Thank you very much. We heard today that not everybody is getting the ambient technology, and wish we could do that. And I think under your administration, you came up with a biosimilar for insulin. I thought that was great. Can we, instead of buying, build something? Because it seems like there's so much open source technology that we should be able to put a team together and get that done. I know it's not. It's just a thought.
Yeah, it's a great question. One I hadn't thought about. We were, at the time I was transitioning, the question was which safety net providers were even prepared or willing having the conversation. I think they were beginning to have the conversation. You see it more where you have, let's say, the UCSF example, where there's a big safety net institution attached to a sort of flagship academic facility where the technology is going to sort of cross those different areas. But standalone institutions weren't even having that conversation. My wife has the privilege of running the LA County Department of Health Services, pretty huge public hospital system, the biggest one in California and certainly one of the biggest in the nation, and they're still scratching the surface on the question. I love the idea of asking, could we do it sort of in-house and locally to create something that hopefully doesn't have the same subscription costs for Medicaid providers. If I were in the role still, I would certainly try.
Any last questions? Greg?
In your role as secretary leading this huge department, you had a lot of interaction with the Senate, the Assembly, and all their staffers. Here we are expecting them to be knowledgeable about dozens and dozens of different topics. Only one of them is health. Do you see the legislature now using AI to better understand the healthcare topics?
I'd want to see the AI they're using before I said yes to that. I mean, it's a great question, and I think what's exciting about this topic is each one of us could spend 30 minutes alone and come up with a bunch of uses which really might advance, in this case, legislation and where we're going as a state on the topic of AI or direct patient impacts. I think that the TA for that would be pretty significant and could be considered, but it's probably a little ways off.
So, Mark, we have a bunch of folks representing different parts of the healthcare ecosystem, physicians, folks from consulting and hospitals and pediatricians and such. And AI is such a big deal, and you're right, everybody's looking at the elephant from their own perspective, whether it be a hospital or a payer or the government. As you see the role of what role can this crowd play in kind of advancing AI, not only in their organization, but even to Greg, your point, how do we keep our legislators informed about it? What could this team, could these people here be able to do or should be doing?
I mean, for me, it's that, you said it, Greg, I alluded to it earlier. I think this need to educate legislators on what would make sense in this moment and where is this whole field going? Yeah. How can it transform issues? Just know front of mind for a legislator is going to be their constituents. I think the strength and support of our labor partners is real, and there's a real concern and threat, whether it's, as we talked about, replacing people or aiding folks and creating new roles and responsibilities. I think we have to be thoughtful about how we explain the impacts. A clear way to get booted out of the room is to say how many jobs someone's constituents are going to lose. And I think we are right in the prior panel to talk about how we're a long way from that. But I think that's a real fear. And legislators are going to be pretty keen on that. The cost, the ability to make sure that this is accessible everywhere. I think if this crowd can speak to that and help support legislators in really transitioning the thinking from we're on guard, we're defensive, because I think that's where so many people are today, to there might be an opportunity here, here's the road to exploring that, would be really useful. One of the things I definitely had the privilege of doing a lot of interactions with residents and students, and they would ask, how do we get involved? And it's the same message here. I mean, the legislators, you put them there. Help them understand sort of your world, your work, and where their opportunities lie. And it's pretty impressive. After a couple of years, you can see the snowball trickle, and a number of new bills are advanced and signed, and we actually change how the state operates.
Well, join me in thanking Mark for this great presentation. Okay, believe it or not, all good things must come to an end, and we are coming to an end of the Healthcare Forecast Conference. I would love to hear from folks any themes that resonated during the whole day. You can just shout out, or if you have a phone, just one or two word themes. Anyone that they are taking back with them. Caution, okay. Anybody else? Innovation, thank you. Yeah, of course. Hope, okay, thank you. I agree. What I took away from all of this is, yes, there was a big talk around affordability, but alongside affordability was innovation. And so the first half of the day, we heard all about, I shouldn't say doom and gloom, but I should say reform and more reform. But at the second part of the day were all the opportunities that lay ahead of us, right? Whether it be AI in healthcare or with the cutting edge treatment in obesity, per se, in the epidemic. I'm a primary care physician, and there are very few times when you get to see such cutting edge medications coming, Hep C, HIV, TB, penicillin. And so obesity is one of them, but at the same time, it is also an affordability access issue. So I would tell everyone to leave with hope and innovation as the theme. And before I close, I want to thank Hope for actually organizing this whole event. Please give her a round of applause. And Diane, who's sitting in the back, who's been planning it for like months and months, and all the planning committee who made this happen. And thank you again, folks, for coming and making this very fun. The party doesn't end, it goes on. Our reception starts just outside these doors, and hopefully we'll see many of you next year. Thank you again.